Good afternoon. I'm here to talk to you about pruritus, what to do about the itching. My name is Alexis Morvant. I'm the Chief of Pediatric Palliative Care here at Children's Hospital, New Orleans. I'm also an Assistant Professor of Clinical Pediatrics at LSU School of Medicine. I'm a faculty member for the Tulane Hospice and Palliative Care Fellowship as well. I'm really excited to talk to you guys about my topic. Big thank you to Kathy Perko and the team for putting this together so we could all continue to learn together. So I hope that you could leave my lecture today by being able to illustrate that pruritus is a symptom and serious illness that really does negatively affect quality of life, and that we should be able to identify that's a common side effect, especially with opioid usage and other drugs. And I hope that you could describe several approaches for treating pruritus when faced with this symptom, also understanding that there's just a lack of empirical evidence of exactly the right way to do this. So pruritus, it's something that is experienced by all humans and animals, as you can see by these pictures. And so at some point in our lives, we're all going to feel something that's itchy. And usually how it's described as an unpleasant sensation that provokes the sort of motion of scratching in a particular place on someone's body. It could be localized. So it could be here, I have this ant bite right here, this is itching right here, I have pruritus, or it could be generalized to where there's a rash that's showing up on the skin, or perhaps it's something systemic beneath the skin that's causing pruritus or the sensation of pruritus. It could be something that comes on acutely, meaning that it comes on really suddenly and it's going to go away. There's a time limited sort of time that the patient's going to experience this, versus something that's chronic, usually from maybe something that's systemic that's causing the patient to experience pruritus. And when you really go back and really look at the pathophysiology, it's really, itching is really poorly understood of exactly what causes what, which makes then our treatment plan really challenging if we are still having trouble understanding exactly what it is. So as usual, when we're thinking about any symptom in serious illness, we're going to start with evaluation. And so in general, I like to start with a stepwise approach to pruritus, because even though we don't have data of what's really going to work well, what's really not going to work, it's really good to say, okay, if I have this particular type of patient, these are going to be my steps in order to provide an empiric treatment plan. It's really not extremely common. And on the adult side, literature shows that it was present in about 4% of patients that experience cancer. And I think many children might be able to say, hey, doc, I'm really itchy. It's right here. This is itching me. And also in serious illness, we have children like neonates, or maybe children who are nonverbal, who have global developmental delays and are not going to be able to have that voice. And so with that being said, we should always keep it in the back of our mind if there's sudden discomfort and we don't really have a rhyme or reason, especially if we just started opioids. And the key when we're thinking about pruritus is going to be to look for primary skin changes. And so what are we seeing? Do a full body scan as it is at a particular place that's localized on the body, because that might change our treatment plan versus something that could potentially be systemic. And watch out, because kids are going to scratch, and so make sure that we don't confuse the excoriations as the site of the pruritus itself. What are some other systemic considerations? So we have uremic pruritus, which is going to be sort of our chronic renal dysfunction. And also from the liver perspective, cholestasis is very, goes hand in hand with itching, with systemic itching, also hepatitis. From a heme perspective, iron deficiency anemia, thyroid issues. From an endocrine perspective, diabetes, other things to consider, multiple sclerosis, drug reactions, psychosis, and AIDS. And then specifically when we start to think about cancer, leukemias and lymphomas are generally going to cause a higher rate of pruritus, systemic pruritus, when compared to other solid tumors. And so we're going to talk more about treatment plans, but when we are thinking about malignancy, we could also have skin metastases that really cause a nerve entrapment that could cause a neuropathic induced pruritus. And in those instances, we really want to hone in on our gabapentin, but we'll get to treatment in a minute. Other malignancies, to where it's not a solid tumor, maybe not a leukemia lymphoma, you might want to take a look at a different part of our toolbox, and of course CNS tumors. So again, when we're thinking about serious illness, we want to try to treat the underlying causes. Is there anything reversible about the thing that we're seeing in this new presentation of itching? And don't forget that even though these kids are having experiencing a serious illness, they still are going to have some of the same things that a general pediatrician might see in their clinic in an otherwise healthy child, such as eczema, dry skin, contact dermatitis. And if they're on opioids, that should be really, really high on your differential of opioid-induced pruritus, which we're going to talk about in depth in a moment. Other things to consider: is there an infection localized in the skin, insect bites such as ants? Kids are still going to get bit by insects. And so you just want to kind of still look at that whole patient outside of just thinking what in their serious illness could be causing this symptom. It could be something unrelated. Drug reactions, iron deficiency, anemia, thyroid dysfunction, those things could be considered reversible. So what do? So as always, we want to really hone in on our non-pharmacological interventions. And the first thing when we think about itching, pruritus, is really to think about enhancing our skin integrity management, such as ensuring that the skin itself is moist, that the environment is cool and humidified. We might want to use cool compresses, emollients, to really make sure that a kid that's going to have some kind of other reason for their skin to be itchy, if their skin is dry, it's just going to exacerbate sort of that overall experience of itching. Really hone in on your interdisciplinary team. So we want to say, hey, let's utilize our child life specialists and their excellent perspective on children with serious illness, integrative therapy, psychology, etc. And what they could provide are other tools that are non-pharmacological in approach, such as mindfulness, distraction, calming techniques, guided imagery, healing touch or Reiki, aromatherapy or massage. And I put those in different boxes just because some children may not want to put something on their skin, such as aromatherapy, but it might still be helpful for smelling, and some kids may not want to be touched by a massage. And then ultimately reassurance and counseling to ensure that we're doing all the things we possibly can before we get into our pharmacological approaches. So when we think about pharmacological interventions, the first thing I want to talk about is opioid-induced pruritus. We should always utilize a stepwise approach when we're faced with opioid-induced pruritus. And so what is this? Usually it's going to come on within some time period after starting possibly a PCA with a continuous infusion, or maybe new opioids for some kind of new symptom. And kids are generally going to be either scratching if it's a neonate. You might see them just feel uncomfortable. They look discomforting. And it's just something to kind of keep high on your differential when you're thinking about what could be causing itching. I just started a PCA, or I just started opioids. What this should be high on our differential. So again, we want a stepwise approach. And generally, it's okay to trial antihistamines. We don't think that the benefit is likely going to be from the actual relief of itch sensation rather than more just causing a little bit of sedation. The things that I really like to use personally is a naloxone drip, just to see if I am getting good pain response and I'm getting a desired effect from my pain management plan. Then I usually start a little low dose naloxone in the background, or you could consider intermittent dosing as well. And the other thing to consider, which I learned whenever I was learning about pruritus, is ondansetron is something to really keep in your toolbox. And again, just like antihistamines, there's a very low side effect profile for ondansetron. And that's dosed every 8 hours. Ultimately, if despite maybe an antihistamine, ondansetron, maybe putting naloxone in the background, especially if you're not getting good pain management either, consider an opioid rotation. And what studies have shown is 65% of PCA rotations is due to pruritus. And so what are some other pharmacological interventions? Antihistamine, again, just like we talked about in opioid-induced pruritus, antihistamine is a great place. It has, to start, it has a low side effect profile besides sedation, and so it's really about the goals of the family at that point. Ondansetron or Zofran, also low side effect profile, could be helpful for opioid-induced pruritus. It might be helpful for other systemic causes, but mostly the literature we have is about opioid-induced pruritus. Secondly is gabapentin. I don't know many kids receiving palliative care that are not on gabapentin for many different reasons. And again, this is a low side effect profile. We might see a little sedation, and that's why we kind of start low and slow and really slowly titrate upward. It's really beneficial for neuropathic induced pruritus and potentially others. Topical capsaicin, menthol and camphor, lidocaine patches, and just making sure that with all of these topical sort of things, making sure that there's not open excoriations that could potentially cause infection or more pain. Corticosteroids and diphenhydramine creams. Less commonly used would be like in the kind of part of your toolbox that you're not going to use in your stepwise approach for every single kiddo, but paroxetine, mirtazapine, sertraline, tacrolimus, and that's really for more severe chronic things that are not going to get better. So, in summary, I hope that you could all develop your own stepwise approach to pruritus. We don't have great data of saying what works and what doesn't work, so it's really about us choosing just an approach that we do for patients so that there's a method to our madness. We really want to lean on your interdisciplinary team to ensure that we're taking care of all the other aspects of serious illness, such as, really utilizing child life therapy, psychology, and integrative therapies. And again, just consider an empiric treatment for pharmacological approaches. And with that, I'm going to say thank you for your time. I appreciate you. I hope that your learning continues, and I hope to meet you down the road. Have a great day.